Good morning and welcome to Navigating GI and Hepatic Challenges in CF, the current insight and future directions. Today, my name is Dr. Folashade Jose, not Jose. I do speak poquito Spanish, but so is Jose. Today, I will be pleased to be co-moderating the session with Dr. Lauren Lassa, and we'll be discussing navigating GI, hepatic challenges in CF and current insight today. Just briefly, cystic fibrosis is increasingly recognized as a multisystemic disease, with gastrointestinal hepatic complication emerging as important contribution to overall morbidity. As CF care continues to evolve in era of CFTR modulator therapy, our understanding of this manifestation must also deepen. So this session will explore the evolving landscape of hepatobiliary involvement in CF, including challenges of diagnosing, monitoring, and treatment. We will also be highlighting updates in the management of enteral nutrition, pancreatic insufficiency, constipation, ileus, and meconium ileus syndrome, all within the context of post-modulator use. In addition to clinical updates, we will engage in complex discussion and provide direction in hepatic care for individuals with CF. We hope this session fosters collaboration, sparks new ideas, and ultimately enhances care of our patients. The format of this workshop will be 2 hours of abstract focus session, 15 minutes presentation, each followed by 8 minutes of Q&A. We will be recording this session. We have no disclosures. Each individual presenting today, we have their own disclosure presentations. What are the learning objectives? First, identify and evaluate emerging diagnostic and monitoring approaches for early detection and risk stratification for hepatic and pancreatic complications in individuals with CF in the era of highly effective CFTR modulators. Secondly, analyze pediatric health information system data to assess the impact of CFTR modulators on the clinical management of common gastrointestinal symptoms in children with CF. Thirdly, formulate evidence-based approaches to optimize nutritional management, guide enteric support decisions, and structural long-term gastrointestinal care in the context of highly effective CFTR modulator therapy. This session brings together researchers and clinicians to share insight across 5 key areas. First, hepatobiliary biomarkers. Early findings from the BEGIN study on liver changes in young children post-ETI therapy. Pancreatic function restoration, identifying predictors of recovery in children with CFTR modulators. And not to forget, nutritional transitions in a retrospective look at G-tube removal following modulator therapy. GI burden of acute care. We're going to our emergency department to look at G-tube removal following modulator therapy. GI burden in acute care is very important as well. So we're looking at complication pre and post modulator errors. Radiographically, we are looking at advanced imaging, the role of quantitative MRI in assessing CF-related liver diseases. I'm going to call on my co-moderator today to introduce our fantastic and amazing researchers today. And I call on Dr. Lauren Lassa. Thank you so much.
Great, thanks, Dr. Josie. So I'm introducing our first speaker, Dr. Daniel Liang, a co-Texan, who honestly, I don't know if he really needs any introduction from me, but he is the Director of Pediatric Hepatology and Liver Transplant at Texas Children's and Baylor College of Medicine, and he's a clinician scientist who has dedicated his career to studying CF-associated liver disease, hepatobiliary manifestations, and especially serum and imaging biomarkers in CF. We're pleased to have him come present some data from the BEGIN study.
Okay, thank you so much to the organizers of the conference for the kind invitation. It's really my honor to present preliminary data regarding hepatobiliary markers of liver injury both before and after 12 months of highly effective modulator therapy on behalf of our BEGIN study group. I don't have any disclosures. And this BEGIN study group is a very, very young cohort of children with CF. And I hope to sort of bridge together the clinical relevance as it pertains to CF liver disease. As many of you may know, the development of advanced CF liver disease, or advanced CFLD, occurs quite early, by the first decade of life in up to 10% of children with CF. Next to respiratory complications, this really poses a very, very high risk of mortality. It's unknown if highly effective modulator therapy will improve or alter the natural history of advanced CFLD in young children with CF if started early. Fittingly, there are some concerns for highly effective modulator therapy related hepatotoxicity in this young cohort with CF if started so early. And then lastly, the long-term impact of these highly effective modulators on hepatobiliary markers, including liver stiffness, in young children with CF is relatively unknown. BEGIN is a prospective study to evaluate biological and clinical effects of significantly corrected CFTR function in infants and young children. It is a two-part multi-center prospective study of, again, young children, 2 to 5 years, both before and after initiating highly effective modulator therapy. While there is an important prospective natural history component of the study in Part A, I'm going to be focusing primarily on Part B, where we observe the effects of highly effective modulators on a variety of issues, including growth, GI health, liver and pulmonary outcomes, and of course, I will be focusing primarily on liver outcomes. This gives you an idea of the BEGIN study visit intervals and an overview. Again, we will be focusing on Part B, which is pre and post-modulator, and the current data set, the data cut is right at the 12-month mark. And you can see that Part B has an extended enrollment period of up to 5 years, which is really exciting and extremely important if we're ever going to determine if highly effective modulators alter the natural history of advanced CFLD. So what were some of the hepatobiliary assessments that we have captured in BEGIN? We'll first start off with just the standard of care liver biochemistries. These include AST, ALT, GGT, and direct bilirubin. And these are paired with biomarkers. These biomarkers are calculated and collected before and after highly effective modulator therapy. These include APRI and GPR. And lastly, we do have a subset of patients participating in our FibroScan sub-study, which collects liver stiffness measurements a year after highly effective modulator therapy. All of the upper limits of normal are either supported by pediatric-specific literature or liver biopsy-validated thresholds within cystic fibrosis. And there on the right, you can see the upper limit of normals selected for this particular study. Here's our statistical analysis plan. This plan really allowed for us to account for both fixed and random effects, capturing individual variability and fully quantifying uncertainty in most of our estimates. This gives you a brief overview of the baseline characteristics. You can see that we had 238 study participants overall. These children were quite young. They had a mean age of 3.9 years with a standard deviation of 1.5. The overwhelming majority of these patients were white, and the majority of them were homozygous F508del and overwhelmingly pancreatic insufficient. You'll see in our liver stiffness sub-study, we did not have 238 participants. We only had 58, given the availability of that technology at the pediatric sites. So I have to say, we were quite surprised by the high proportion of young children with CF who had liver labs that were greater than 1.5 times the upper limit of normal. As you can see here, greater than 42% of children had abnormal AST, greater than a quarter had elevated ALT, and a whopping 63.6% were found to have an elevated APRI, and this was before highly effective modulator therapy. Reassuringly, you can see here that after 12 months of treatment, most of these liver labs either stayed the same or improved. I think very reassuringly for those very concerned about hepatotoxicity, there was really no increase in abnormal values. You can see that abnormal AST declined a little bit to 38.4%, but abnormal ALT reduced by more than 50%, from 25.5 down to 11.3%. GGT, direct bilirubin, and GPR really did not change after highly effective modulators. Interestingly, shown here in red, there was a 2.5-fold increase in the percent abnormal with direct bilirubin, and we'll talk a little bit more about that momentarily. Now, just to give you guys a sense of direction of where these transaminases and liver labs went over a 3, 6, and 12-month period, this is the percent abnormal in AST, ALT, and other labs. You can see here in green that there is a sustained reduction in the percent patients with abnormal ALT. And here in red, very interestingly, you see a sustained and increased elevation in direct bilirubin. And this likely has something to do with the interactions with OATP transporters, as it is required for the reuptake of conjugated bilirubin. Taking a closer look using this forest plot, you will again appreciate that after 12 months of highly effective modulator therapy, there was a reduction in the proportion of children with abnormal ALT, and meanwhile, an increase in the proportion of young children with elevated direct bilirubin. But are these changes clinically meaningful? And I'll sort of let you guys be the judge of that on this next slide. So indeed, after 12 months of highly effective modulator therapy, we did appreciate a reduction in AST, a reduction in ALT, and an increase in direct bilirubin. And on the y-axis are the actual laboratory values shown there. Are those clinically significant? Some might say yes, because perhaps you're reducing the proportion of patients whose labs are greater than 1.5 times the upper limit of normal, which has been previously shown to be a predictor of advanced CF liver disease. But for many of the hepatologists in the room, a 5-point drop in your AST or ALT, at least in the short term, is not very clinically meaningful. And what do I mean by this? So even though there was an 8.5% reduction in AST, in reality, the mean value dropped from 42.5 to 38.9. For ALT, there was a 15% reduction from 34 to 29. And from a direct bilirubin perspective, while it increased by 19.3%, the elevation only went from 0.17 to 0.20. So again, in the short term, these numbers may not suggest any truly clinically meaningful change, but this is only after 1 year of treatment. If they sustain this type of trajectory over an 8-9 year period, perhaps it could be quite meaningful. We're going to transition over to biomarkers of liver fibrosis. APRI and GPR have been the biomarkers that have been validated using liver biopsy in patients with cystic fibrosis. Of course, these are alternative, non-invasive methods to detect varying stages of fibrosis, and these biomarker indices might actually be more specific than liver labs alone because they include the variable platelet count, which has been shown to drop in patients with advanced CF liver disease. And again, very surprisingly similar to the standard of care liver biochemistries, 63.6% of our patient population had an APRI greater than 0.264, which is associated with an increased risk for CF hepatobiliary involvement, while only 8% had a GPR greater than 0.2. And you'll see here that after 12 months of highly effective modulator treatment, that there was really no change in either of these biomarkers. What about changes in liver stiffness? First of all, is 12 months of treatment sufficient time to really expect changes in liver stiffness or not? You can see here in this plot on the far left that the proportion of patients with elevated liver stiffness, shown here in red, really doesn't change even after a year after treatment. However, when you look at the mean liver stiffness after a year of treatment within these 40-plus children, you see a 1.2 kilopascal reduction. And we'll touch on whether or not that is statistically significant or clinically meaningful in just a second. Not surprisingly, platelet count over this one-year period did decline, but again, you will see that these platelet counts, even at their lowest levels, are far within normal clinical range. So I'll let your eyes adjust just a little bit to this table, but very similar to our observations that a high proportion of young children had elevated AST, ALT, and APRI, an unexpectedly high proportion of young children with CF also were found to have elevated liver stiffness. What do I mean by this? We know that a liver stiffness greater than 5.95, at least per our CF Foundation consensus recommendations, ought to increase your radar and suspicion for CF HBI. A very surprising 18% of young children with CF were found to have liver stiffness concerning for CF HBI. Using a higher threshold of LSM of greater than 8.7, this came from Peter Lewinden's work that was liver biopsy validated, 9% of these young children are predicted to have F3 fibrosis or higher. So this was very surprising and again begs the question whether or not these specific LSM thresholds relate quite as well in this young cohort of children, since many of the biopsy validated studies were performed in adolescents and young adults. And then for the clinicians in the room, you'll see that mean liver stiffness before and after highly effective modulators dropped by 20%. In many other diseases, a reduction by 1 kilopascal or more might be clinically meaningful, but you can see here in red that the confidence intervals were very wide, and this is likely due to a small sample size. And perhaps with greater measurements and perhaps with a greater period of time, this may be more clinically meaningful. And then lastly, we focused our attention to those who had abnormal APRI or abnormal GPR at baseline. Did those who might be at higher risk for CF-HBI tend to respond more favorably to highly effective modulators? And again, I think you can appreciate here in red, those who had an elevated APRI at baseline have a very different trajectory in their ALT and AST compared to those who had a normal APRI. This same trend was also seen in patients with an elevated GPR at baseline. You see this trajectory looks quite different, and the direct bilirubin also came down. And so obviously with 4 or 5 years of follow-up, if this is sustained, this perhaps may be a meaningful biomarker suggesting a change in the natural history of disease. So in conclusion, we do describe a higher than expected proportion of young children with CF with elevated liver tests, notably AST, ALT, APRI, and liver stiffness, even before receiving highly effective modulators. It's really unclear if these prior established thresholds should apply in young children or not. Do these predict CF-HBI in the young cohort is left to be seen. Highly effective modulator therapy for 12 months in young children was not associated with hepatotoxicity. I think that should give many of us reassurance. Liver stiffness did not appear to change or worsen, but as I showed you, there was a trend towards reduction even after a year. We did notice a 50% relative reduction in those with abnormal ALT and a 2.5-fold increase in those with abnormal direct bilirubin. This is likely, again, related to the pharmacology of ETI in particular, but again, not clinically significant. Children with CF with elevated APRI and GPR suggestive of CF-HBI demonstrate a improved trajectory in their AST, ALT, and GGT, suggesting potential benefit in CF-HBI, but that needs to be determined at a much later time point. And lastly, long-term follow-up of these biomarkers of liver disease within BEGIN and other studies such as ENHANCE, RECOVER, and other global studies may inform the potential benefit of early, highly effective modulator therapy in changing the natural history of this disease. I want to thank our amazing BEGIN PIs, our TDN study team, as well as our BEGIN collaborators at each of these sites, and of course recognizing the CF Foundation for the vision to fund this study, and of course our amazing patients and their families. Thank you very much.
Does anyone have any questions?
I can start with a question. Oh, okay.
Okay, Mike Narkowitz, Colorado. A couple of comments, Dan, and then a question. One, I think it's really important that we align all the biomarker cutoffs across all of the studies. You've used much lower cutoffs than used in PROMISE and RECOVER. I know why you did it, but I think as the data has come out, the cutoffs probably need to be a little bit higher in that space so that we can compare and make sense out of it. And that's a plea to everyone who's doing these studies, that we unify the cutoffs with it. The second comment is, at least in the literature now, 30% is the variability attributed to elastography. So I think you're right. You know, your change is only 20%, and so it's outside of statistical range. I think we need to be rigorous at that, and at least some of the data that Jay showed the other day suggests the variability may be more in older kids. We don't know here. To elastography, you know, Maureen Jonas showed in CF actually that higher liver enzymes were associated with higher elastography. And have you had the chance, and you probably haven't, to take the data, use some cut point for your AST or ALT, and look if that is more correlated with the higher elastography at the start in these kids? Because you're right, they have much higher transaminases just going in. So I think looking to see if inflammation is playing a factor in the elastography, you'll have the ability to look at it, would be really helpful to the community.
Yeah, that's a great suggestion, Mike. And, you know, we made this point at the liver workshop is your selection of upper limits of normal is very important in calculating APRI and FIB4, and your selection of your thresholds for CF-HBI is also very, very important. I think the reason why we used the more biopsy-validated one, even though it was lower, was just to explore at this very early time point whether or not there was a signal of concern. But yes, I agree. I think that especially since our liver biopsy studies had less than 100 patients, we have to be cautious, absolutely. And your point's really well taken about inflammation and its impact on liver stiffness, and we'll take a look at that correlation.
Congratulations on your study. I wondered if you have any data on the hepatic ductular enzyme 5' nucleotidase.
Sorry, could you repeat that question? The hepatic
Do you have any evidence of 5' nucleotidase, a ductular?
Oh, we do not. We have collected bile acids and some FGF19 markers, but we've not collected that specific lab. Do you mind if I ask your specific interest in that particular marker?
Well, I've used that marker all of my career, and I think it has significance particularly when you have an elevated direct bilirubin. And I guess that's the answer.
Oh, okay, thanks. Always happy to learn, so thank you for the suggestion.
So Meg Sate, UT Southwestern. So I have sort of and I don't know the answer to this, even what I think about it, but just wanted to get your take on. So with the way we are diagnosing CF-HBI, right, you showed a pretty significant number of 2 to 5-year-olds that we're labeling with this diagnosis. What are your thoughts on, I've sort of not undiagnosed anyone of CF-HBI yet, but clinically, it becomes a little more stressful for the patients and the families. And I don't honestly know what I think, like, do I really believe that this 2-year-old whose APRI is flagging high, is that really equivalent to liver disease? Like we in the future, right? Like we're just trying to understand what's happening. Mm-hmm. So how do you I'm just curious, how are you applying this clinically to your patients? Because one thing is to study it and think about it in a very academic way and try to understand what this really means for our patients. But another thing is that we're bringing it to the patients and the families, and how do we kind of explain that to parents?
Yeah, great question. I think the important perspective on this is to not overinterpret, and again, not relying on a single biomarker, let alone two. I think you really need a combination of imaging, standard liver biochemistries, maybe a biomarker, and of course, your physical exam. I wouldn't make any clinical recommendations without all 5 of those. And again, I think it's very academic and very interesting that we're studying these potential surrogates of liver disease and surrogates of liver fibrosis, but we have to be very, very careful to not overinterpret them.
All right. Thanks, everybody. Oh, go ahead.
I have a question for you real quick. So how should clinician interpret the increase in the direct bili, knowing that there's improvement in the ALT and AST? Just for the clinicians in the room, how should they interpret that direct bili?
Yeah, well, again, I think it's important to acknowledge that a direct bilirubin, the highest it got was 0.2, which in most labs are within the upper limit of normal range. So there was a trend towards increasing, but the absolute value was clinically normal. No. So I'm not suggesting that highly effective modulator therapy causes cholestasis when there's no evidence of hepatic inflammation. Yeah.
Okay. So just for the clinicians, don't do anything different like what you've been doing. So. Okay.
Quickly from Dr. Sellers.
Yeah, first off, I just want to congratulate you, Dan, and you, all your co-investigators on, studying this. I think it's very important. And I think that as we've discussed during this meeting, various sessions, I think it brings a lot to light about how we use all these different tools. And I think it is important, and you pointed out that as you get into these younger age groups, that it's important to look at the different studies that have established certain thresholds and sort of cutoffs and different things and what age ranges they used and take that into account. My one question for you, and I don't know if you have an answer to this, I mean, you showed, like many of us have seen and through other studies, that platelets will decrease on ETI therapy. And as you know, that's an important part of APRI or GPR. And so how do you start to think about how do you do those analyses and what those things mean, especially when, as was discussed yesterday, these thresholds were done at a time pre-ETI where we're not seeing that sort of ETI effect on platelets.
Yeah, well, that's the beautiful part of the BEGIN study is we have Part A. So we have Part A in which we follow the same liver enzymes and platelet count. And if I'm not mistaken, in Part A, pre-ETI, there's also a reduction in platelet count. So I don't feel strongly that the reduction in platelet count is really related to ETI. Certainly the association of time of being on it, we recognize, but platelet count is known to drop in normal children with age, and I believe in our Part A study does as well.
Okay, so maybe there's some differences between the sort of the younger age and sort of older individuals and even those that may have
Yeah.
increases on ETI with their platelet counts?
I don't know, actually, but yes, there may be a key difference in these 2 to 5-year-olds compared to 10 to 15-year-olds.
Okay.
Thanks for bringing that up.
Thank you so much.
So we're going to bring Dr. St. John up here. She's going to present to us. And so she's a third-year pediatric gastroenterology fellow at Riley Hospital for Children in Indianapolis. Her research focuses on pediatric cystic fibrosis and pancreatology, with a particular interest in improving outcomes for children with pancreatic disease. She plans to stay at Riley after she graduates fellowship and continue in the CF space.
My name is Audra St. John, as Lauren introduced me as, and I am a third-year fellow at Riley, and I'm very excited to present to you my fellowship research project, which is predictors of pancreatic function restoration in children with cystic fibrosis on CFTR modulators. I have no relationships to disclose for this presentation. Briefly, some background information. As we all know, about 85% of people with cystic fibrosis develop pancreatic insufficiency within the first year of life. As we've seen throughout this conference and in the last several years of our research, there is some data that CFTR modulators may preserve or even restore pancreatic function, particularly when initiated earlier. However, to date, there's limited research on the predictors of regaining pancreatic sufficiency after starting modulator therapy. The aim of this study is to identify factors linked to regaining pancreatic sufficiency, defined as a fecal elastase of greater than or equal to 200 in children with CF on modulator therapy. We hypothesize that earlier initiation with CFTR modulator therapy is associated with increased odds of regaining pancreatic sufficiency, and individuals with class 3, 4, and 5 mutations have increased odds of becoming pancreatic sufficient. The design for this study is a single-center case control observational study. We included children with CF who have been on CFTR modulator therapy for over 2 months and have a history of pancreatic insufficiency defined as a previous fecal elastase of less than 200. The outcome of interest was regained pancreatic sufficiency, defined as the fecal elastase greater than 200 after starting CFTR modulator therapy. And variables of interest included demographics, anthropometrics, medication history, and GI symptoms. On day 0 of our study, our participants submitted a stool sample which was sent for fecal elastase. They also submitted a survey which included a PAGI-SIM questionnaire. That is a validated survey of severity of GI symptoms. We also included some study-specific questions looking at frequency of GI symptoms, specifically malabsorptive symptoms. And then each participant provided a height and weight measurement. We had 66 participants submit stool samples. The mean age was 8.3 years, and we had a range of 2 to 18 years. The participants were predominantly male and predominantly non-Hispanic white. We were very excited to find that 17 of our 66 participants became pancreatic sufficient, and that was 25.5%. We then looked into different variables which might help predict who would become pancreatic sufficient. Starting with demographics, we found no difference between the groups, the pancreatic insufficient group and pancreatic sufficient group. Particularly mean age, gender, race, ethnicity were all very similar between the two groups. Similarly, anthropometric data did not have any effect on pancreatic function, looking at height, weight, and BMI. Next, we looked into GI symptoms. We did find that an increased percent of those who had pancreatic insufficiency reported steatorrhea. Symptoms such as diarrhea, fatigue, epigastric pain, heartburn, and appetite were not associated with their pancreatic function. We also found very similar PAGI-SIM scores between the two groups. This is a bar graph that shows us pancreatic sufficiency based on the GI symptoms. On the x-axis, we have our different symptoms, and on the y-axis, we have pancreatic sufficiency, and on this scale, ranging from 0 to 40%. In purple, tells us that the symptom was present, and in blue tells us that the symptom was absent. So focusing on steatorrhea, which was clinically significant, we found that those who reported steatorrhea had a significantly lower percent pancreatic sufficiency compared to those who denied having steatorrhea. That was 9.5 had steatorrhea and pancreatic sufficiency, and 34% had no steatorrhea and pancreatic sufficiency. We saw similar trends with bloating and lower abdominal pain, and those approached significance. Next, we looked into genotype. We found that a class 3 mutation had higher rates of becoming pancreatic sufficient compared to those who only had a class 1 or 2 mutation. And similarly, having a class 3, 4, or 5 mutation was associated with increased odds of having pancreatic function recovery. This is a table that shows us the different classes of mutations for this particular group. We had 14 individuals having at least one class 1 mutation, which is our defective synthesis. We had 65 of our 66 participants had at least one class 2 mutation, and that's defective trafficking. Of note, 40 of the 66 participants in the entire study were F508 homozygous. We had 7 individuals with class 3 mutations, which is our gating mutation, and then 1 participant who had class 4 mutation, which is defective conductance, and 1 participant that had a class 5 mutation. And if we remember, our class 4 and 5 mutations are typically associated with less severe disease and pancreatic sufficiency at baseline, though we know that these 2 participants who had class 4 and 5 were pancreatic insufficient prior to starting modulators. We found that there were higher rates of regained pancreatic sufficiency among those with class 3, 4, and 5 mutations. This is a bar graph that shows us percent pancreatic sufficiency by different genotype classes. On the x-axis, we have our different genotypes and mutations of interest, and on the y-axis, percent pancreatic sufficiency. And if these numbers are a little small, ranging from 0 to 80% on this scale. So for those who had at least one class 3, 4, or 5 mutation, in purple tells us that that mutation was present. 66.7% with the class 3, 4, or 5 mutation had pancreatic sufficiency. Those who only had a class 1 or 2 mutation present and no class 3, 4, or 5 mutation, significantly lower percent pancreatic sufficiency at 19.3. Looking at that class 3 mutation alone, which is the gating mutation, we found that those who had at least one class 3 mutation had 71.4% frequency of pancreatic sufficiency compared to the rest of the group who had 20% pancreatic sufficiency. And then our largest genotype was our F508 homozygous mutation, and we found that 25% with a homozygous mutation had pancreatic sufficiency, which is very similar to those who were not homozygous at 26.9. The next variable we looked into is CFTR modulator exposure. We found that younger age at the time of initiation is associated with increased odds of developing pancreatic sufficiency. We found that there was no significant difference between the groups based on other variables related to our modulator exposures, such as compliance, current modulator therapy, time since starting our first modulator, and time on our current modulator. We did consider dosing as a possible variable associated with becoming pancreatic sufficient, but of note, everyone in this particular study were on standard dosing. So we found that younger age at the time of CFTR modulator initiation was associated with regained pancreatic sufficiency. So this bar graph tells us between the two groups, pancreatic sufficient in purple and pancreatic insufficient in blue, the difference between the mean age. You can see in purple, pancreatic sufficiency, the mean age in years was 2.3, and significantly higher mean age at the time of CFTR modulator initiation in the pancreatic insufficient group at 4.6 years. Along those same lines of CFTR modulator initiation age, I wanted to show a scatter plot with our different fecal elastase results. So on the left, we have our preliminary fecal elastase results by age at the time of CFTR modulator initiation. And this is our pre-modulator fecal elastase result. And as you can see, everyone is below the dotted line of 200, which was part of our inclusion criteria. But after modulator therapy, we see that the 17 participants who have their fecal elastase greater than 200, I think the most important thing that I wanted to bring to your attention was that after age 6, there are no participants that had pancreatic sufficiency. And on average, those who are 7 to 14, their fecal elastase was 15. We did find that there was a higher rate of regained pancreatic sufficiency in participants who were first treated with ivacaftor. So in this bar graph, we show the first modulator that the participants were exposed to, and the highest percent of pancreatic sufficiency was found in the ivacaftor group at 57.1. We do note that ivacaftor, all 7 participants that started on ivacaftor first, also had a class 3, 4, or 5 mutation, and therefore we feel that this is likely confounded by the genotype. And lastly, I wanted to talk about our logistic regression analysis. So this is a forest plot that shows us the odds ratio for different variables. Our first variable of interest is the class 3, 4, and 5 mutations, and found that there was an odds ratio of 8.36. So this means that those who have at least one class 3, 4, or 5 mutation is associated with over 8 times increased odds of regaining pancreatic sufficiency. I also included the first CFTR modulator therapy, ivacaftor versus elexacaftor, tezacaftor, ivacaftor, with similar odds ratio of 8.63, though we are aware that this is likely confounded by that first variable of genotype. And then lastly, age at the time of CFTR modulator initiation. We found an odds ratio of 0.7, which tells us that for each year we delay CFTR modulator initiation, there's a 30% decreased odds of regaining pancreatic function. So key takeaways from this study, we found that over 25% of participants regained pancreatic sufficiency after starting CFTR modulator therapy. Genotype, particularly class 3, 4, and 5 mutations, show a positive association with pancreatic function recovery, specifically in our logistic regression models. Starting CFTR modulator at a younger age is associated with increased odds of becoming pancreatic sufficient. Those who reported steatorrhea were less likely to regain pancreatic sufficiency, and other variables, specifically demographics and anthropometrics, were not associated with recovery. So how do we apply this to our clinical practice? We should emphasize the goal of initiating CFTR modulator therapy as early as possible, as later initiation is associated with decreased odds of pancreatic function recovery. We can also use this data to discuss genotype class with patients to help set expectations for pancreatic outcomes after starting CFTR modulator therapy. And lastly, I think it's important to note that all 17 participants in this study who regained pancreatic sufficiency also discontinued their pancreatic enzyme replacement therapy. And we are collecting ongoing data for long-term safety outcomes after discontinuation of enzymes. And this picture I created with ChatGPT. I wanted to take some time to thank the Cystic Fibrosis Foundation for funding my first and second year of fellowship with the Clinical Fellowship Award, my amazing mentors, and the rest of our CF team, and then, of course, our participants for agreeing to participate in this study.
Dr. Narkowitz.
Very nice work, Audra.
Thank you.
2 questions. One, ivacaftor's been around for a lot longer. So did you look at is it really the age it's starting in the genotype, or is it they've been treated for longer because the data out of the IVA studies have shown recovery of pancreatic function as late as 7 to 8 years? Mm-hmm. And so the more recent, more severe mutations have only been eligible, particularly for the young kids, mm-hmm. for a very short time. So have you included duration of therapy in your analysis for recovery?
Yeah, we did not see any difference with duration of therapy. That was significantly different. One of the things and limitations for this study is that we obtained random fecal elastase samples.
Yeah.
And so we had a large variety in time since modulator therapy, but we didn't see any difference. With ivacaftor, I think something that could be confounding for this is that we can start it so much earlier than some of our other therapies. Right. And certainly that's something that we have considered. But with the information we have right now, it's hard to tell.
Yeah, historically you could. And then the last question, your criteria for insufficiency is less than 200. Mm-hmm. And it was helpful to see your graph of starting values. Mm-hmm. So in my mind, there's a big difference if you have a fecal elastase of 100 versus 10. Mm-hmm. So have you looked at whether their random pre-therapy fecal elastase correlates with their likelihood of recovery?
We haven't yet. That's something that I asked our statistician to look into, so hopefully we'll get that information, but not for this particular presentation, but I also am interested in that. There were only a few that their initial fecal elastase was greater than 100, but I think it's certainly interesting to look into what is that change in fecal elastase.
Yeah, and it might be worth both a cut point and looking at just a regression of the values. Mm-hmm. Great.
Thank you.
Very nice work. I think you just answered one of my first questions, which was going to be about, have you controlled for, the timing in which, people on different modulators were able to start that? And I think the answer is probably no, you haven't been able to do that yet, right? It'd be really nice. I guess I'll leave it there. Have you been able to do that?
I don't think we have enough information right now to be able to do that, but I think it's a really important question. One of the things that I like about this study is that we were able to include patients who did not have availability to start until later in life. And so those who are 18 years old, who started when they were 10, or the oldest started when they were 14. I think it's still very interesting data, but not something that we have looked into yet.
Yeah, I think for obvious reasons, it'd be important to be able to match people up, as to say, across different modulators. And you talked about different genotypes, right? That they're starting at the same, times. We talked about, just talked about duration, time, those things. And then, of course, ability of each modulator to impact CFTR restoration is obviously also can be quite different, across, ivacaftor, lumacaftor, encaftor, triple therapies, all these things. So I think as you start putting all these things together, I think those will be important considerations. Right. Thank you. Good work.
Thank you.
Congratulations on your work. I think this is a real testament to the investment that the foundation puts towards supporting GI fellows and focusing on CF. So this was really awesome. You mentioned that there was an increased odds, obviously, in those who started modulator therapy much sooner, but I didn't see what your odds ratio was for those who started it before the age of 7. Was there a specific odds ratio of achieving pancreatic sufficiency if you started it before age 7 versus if you started it after age 7? I didn't see that.
I don't have that ready for us, but certainly something I want to look into more.
Yeah, I mean, you showed us the data and the graphs were beautiful, but I think if you could complement that with what your odds of achieving pancreatic sufficiency, that might be very helpful clinically.
Yeah, of course. I'll include it in the manuscript.
Hi. Great study. I wondered if you have any parallel data on nutritional status, particularly lean body mass in your population studied.
Not lean body mass. We do have information on height, weight, and BMI, but nothing further than that. We did collect some information on if they were having G-tube feeds or supplemental nutrition, and haven't found any differences between the groups there.
So I have 2 questions for you. So I'm going to bring it to the clinical aspect of it, because everything that we do, we bring it to the clinic. So I have 2. One is what monitoring strategies or safety considerations should we recommend for clinicians considering withdrawal of PERTs? That's one part. And the second one would be how might we shape the conversation with families about the potential of pancreatic recovery and the long-term nutritional management. Just because everything we do, we always want to bring it back to the clinic, and now do clinicians utilize whatever findings that we...
So first question is, how should we change our management? And I think this points out that if 1 in 4 people who start CFTR modulator therapy are regaining pancreatic function, we should be rechecking fecal elastase after starting modulator therapy. I don't think I collected enough information from this study, but perhaps from some of the other researchers who are looking into this same topic, we can find out about how long after starting modulator therapy should we be checking for highest yield. But certainly we should be looking to see if we can stop taking enzymes. And then after stopping enzymes, what we are doing for our second part of the study is making sure that we're not seeing any changes in our weight, our GI symptoms, and also our fat-soluble vitamins. We are rechecking a fecal elastase 6 months after stopping enzymes, just to start to collect that data, since we don't know a lot of the changes. And in one of the previous sessions, someone else mentioned that went from above 200 to then below 100. And so running into some challenges on how to approach those types of situations. But certainly collecting a lot more information about how safe is it to stop enzymes and what monitoring should we do. But certainly following the fat-soluble vitamins, which may not show those clinical signs as early as the symptoms or the BMI.
Thank you so much. That was a great answer. Thank you.
Yep. That was a great talk. Our next speaker up, that is Dr. Sansgiri. All right, and she is a second-year pediatric resident now at UT Southwestern Children's Medical Center in Dallas, and she is interested in pursuing pediatric gastroenterology. So we hope a future CFGI fellow, and she has an interest in quality improvement and nutrition and pediatric cystic fibrosis.
Thank you, Dr. Lazar, for such a lovely introduction. Good morning, everyone. I'm so excited to be here today and talk to you about my project that was a retrospective review of removal of gastrostomy tubes after initiating highly effective modulator therapy in our patients at our CF center. I have no relationships to disclose related to this presentation. So I wanted to start out by talking a little bit about CF and nutrition. As we're all very familiar with, nutrition is a critical component of care when it comes to caring for our pediatric population. And this is particularly true when we take care of our children with CF. We've seen as early as the 1970s that poor nutritional status has been linked with worse clinical outcomes. In 2016, ESPN, ESPGHAN, and ECFS released nutritional guidelines that were most recently updated in 2023 with the advent of highly effective modulators. And in general, these guidelines recommend that we monitor nutrition routinely with comprehensive analysis throughout several clinic visits. When we think about these nutritional guidelines, it's important to acknowledge some of the historical perspectives that have shaped these guidelines. In 1988, a landmark study was published that compared outcomes between 2 CF centers, one in Toronto and one in Boston. The CF center in Toronto really promoted a high-fat, high-calorie diet with an emphasis on pancreatic enzyme supplementation. In contrast, the CF center in Boston promoted a low-fat, high-calorie diet with less pancreatic enzyme supplementation. This figure shows the differences in the survival curves at these different institutions. And this was sort of the seminal study that showed us this link between nutritional outcomes as well as survival. Since then, there have been several studies that have followed this one that continue to show this very important link. When we think about our nutritional maintenance goals, for those that are under the age of 2, we like to aim for having their weight for length be at or above the 50th percentile. When we think about those aged 2 to 19, we aim for their BMI to be at or above the 50th percentile. This figure is taken from our 2023 annual data report that continues to show this positive correlation between BMI percentile as well as the percent predicted FEV1. And we can see here this goal of the 50th percentile is highlighted again. What about those who can't maintain their nutritional status through just oral intake? Well, the CF Foundation has outlined some recommendations for when to think about initiating enteral tube feed supplementation. Before they think about this, though, we want these patients to be evaluated by a multidisciplinary care team to be able to look for conditions that might confound this clinical picture and may contribute to nutritional decline of these patients. Once these conditions are identified and treated and appropriately addressed, if patients are still not meeting their nutritional goals, the CF Foundation recommends initiating enteral tube feeds. Once these feeds are initiated, these patients need to be routinely reassessed by their CF team to make sure that they're optimized from a nutritional standpoint. This figure is also taken from the 2023 annual data report and demonstrates the prevalence of tube feeding by age. And as we can see in this figure, tube feeding remains fairly prevalent in our younger populations. It was thought that once these tubes were placed, they would need to be permanent due to ongoing need for supplementation in addition to oral feeds. However, in this new era of highly effective modulators, we've increasingly been seeing the ability to remove these enteral tubes. I wanted to talk a little bit about highly effective modulators as well. In our study, we chose to look specifically at ETI, or elexacaftor, tezacaftor, and ivacaftor. Generally, highly effective modulators correct protein folding, they stabilize our CFTR protein, and help optimize function. ETI was first FDA approved in October 2019 for those aged 12 and older, and has undergone serial expansion for eligibility throughout the years. In June of 2021, ETI was expanded to include those aged 6 to 11, and in April of 2023, eligibility was further expanded to include those as young as age 2. The literature has shown that ETI has demonstrated improvement in nutritional status in those with CF. Despite this, however, there are no standardized guidelines that talk about when one could consider cessation of enteral feeds and ultimate removal of these enteral tubes. Moreover, there have been few studies that have looked at this link with patients taking ETI specifically. With our study, our goal was to evaluate some of the growth changes and understand factors that might contribute to this decision to ultimately remove G-tubes in particular in pediatric patients at our CF center who are managed with ETI. The way we did this is we performed a retrospective chart review of those patients who started ETI between late 2019 and 2023. As a reminder, ETI was first approved in 2019 for those aged 12 and up. We wanted to look at several metrics, including weight, height, BMI, as well as percent predicted FEV1, and we wanted to evaluate these metrics throughout several visits. We specifically looked at the clinic visit prior to ETI initiation, at first reported non-use of the G-tube by patients and their families, at G-tube removal, and then at a subsequent follow-up visit within 6 months of G-tube removal. So in doing so, we started out with 285 pediatric patients at our CF center. Out of those, 35 were found to be on ETI and had G-tubes. And out of those, 13 of our kids were able to have their G-tubes removed. We also wanted to evaluate how old these kids were when their G-tubes were placed, how old they were when they were removed, and at what age they initiated ETI. I wanted to highlight how our clinic visits were performed at our center in particular. The CF Foundation recommends multidisciplinary care with a variety of members of the CF care team. At our institution, that includes a joint visit with our gastroenterologist as well as our dietitian. Our patients are also seen by our pulmonologist as well as a variety of other members of our CF care team listed here as needed. So what did we find for our 13 patients? They were on average 5 years old when they had their G-tubes first placed, on average 11 years old when they started ETI, 14 years old when they had their G-tubes removed, and it took a mean time of 34 months from initiation of ETI to ultimately removing their G-tubes. This figure shows the changes in the mean z-scores for height, weight, and BMI at these various time points. So on the x-axis, you can see the clinic visits, and then on the y-axis, we have our z-scores. What I wanted to highlight on this slide are the light blue curve and the green curve, representing weight and BMI respectively. We can see that we saw an increase in the mean z-scores upon ETI initiation, and this increase was later sustained at subsequent clinic visits. We appreciated a similar trend in our percent predicted FEV1. So you can see again on the x-axis our clinic visits, and then on the y-axis our percent predicted FEV1. And we can see an improvement upon initiating ETI that's later sustained at subsequent clinic visits as well. So we were able to see that ETI improved not only nutritional status, but also pulmonary function through our observations of the mean z-scores for weight, BMI, as well as percent predicted FEV1. This was one of the factors that we considered when thinking about when to remove our patients' G-tubes. There were several other things that were taken into consideration, though. For some of our patients, particularly our older ones who had long-standing G-tubes, they may have experienced issues with their hardware in particular. So things like leakage, frequent dislodgement of their G-tubes, and that contributed to our decision-making. For other patients, they may have needed other procedures that we would try and coordinate with G-tube removal, especially if removal then required subsequent surgical closure of their stomas. And finally, we wanted to take into consideration these patients' quality of life as well as their goals of care. One of the tenets of CF care is ensuring that as a CF care team, we align ourselves with what our patients want for their care. And we wanted to make sure that we were doing just that. And finally, as I mentioned before, nutritional status. So at the heart of this decision-making strategy was this idea of shared decision-making. In general, the discussions for removing G-tubes were initiated by the patients or their families and caregivers. It took anywhere between 4 months to over a year, depending on the patient, from that initial discussion to ultimately removing G-tubes. And in the interim, our patients had visits with our multidisciplinary care team and strong input from our gastroenterologists and our dietitians about when the appropriate time to remove these G-tubes are. Like I mentioned previously, nutritional status was something that factored into our decision-making. However, in those that may not have had as robust of nutritional uptrends, so to speak, we made sure to clarify and agree upon thresholds for replacement for G-tubes in those patients. And of course, like I mentioned previously, all patients had close follow-up within 6 months of G-tube removal. Moving on to some of the limitations of our study. So this was a retrospective chart review. Many of these patients prior to being on ETI may have been on other modulators or therapies. We think that a prospective review or a controlled match study would better help us characterize how significant the impact of ETI was on some of our anthropometric measures. And of course, it's important to acknowledge that we had a limited sample size. Future directions could include thinking about some other patients who had different forms of enteral tubes, such as GJ tubes. So what are our key takeaways for G-tubes in the post-modulator era? It's still very important to consider G-tubes or enteral tube feeds in those who can't maintain nutritional status through just oral intake. There are many patients who still remain ineligible for modulator therapy, and it's important to consider each person on a case-by-case basis. We found that ETI can facilitate improvement in weight and BMI, but when we see that, it's important that we think about every patient on an individual basis and not standardize our decisions when we think about removing G-tubes. It's important that we consider nutritional status, as well as keep in mind our goals of care and our values that our patients and our families hold. And finally, it's critical that we prioritize communication between our patients, our families, and our CF care team to make sure that we work together to provide the best care for our children for CF that we can. Thank you so much.
Do we have any questions?
Very nice, unique data. Thank you for thinking about this because it's going to become more and more common. When you go to publish it, it's such a small number. Think about doing the individual spaghetti plots because I think that will start to help us. The mean did this, but what were the outliers? And did you have to have the discussion about reinserting a G-tube with any family?
So this was a retrospective review that I performed. So unfortunately, I wasn't able to personally participate in these visits with these families. But just knowing how our CF center runs, our visits are fairly extensive with various members of the care team. We also have wonderful EMRs now that allow back and forth communication. So even though that this may not have been limited to just that visit, it certainly, I would imagine, was an ongoing conversation.
So again, you're going to publish this. Of course, you could look at the medical record to look at the text, because again, I think I applaud the idea of when we do this, let's talk about successes and when we might have to come back. But in even that, you may be able to find the record that their weight actually dipped, or we had this discussion and that was motivational and we didn't have to put it back in. But get as much information as you can, because I think this will be very helpful for your prospective study and for all of us thinking about doing this.
Absolutely. Thank you so much.
Yes, I think Dr. Sate may want to pipe up, but we do discuss possibility of reinsertion with all the patients. And we've had some patients who've been a little hesitant to remove because they're very attached to their G-tube. I think we did a good job of selling it early on, right? And that it's a big security blanket for people. And then I think you're right, looking at height and other comorbidities, whether we're worried about liver disease or diabetes, are there other things going on to where you need to have that counseling discussion a little bit more intently. Did you want to comment on that?
I just wanted to comment. We actually haven't had to put any back. So
Yes.
That's right.
yeah, but we have definitely had a discussion with all of them that is a possibility.
So at the end of the time, you haven't had to discuss putting one back.
No.
And you haven't had to. Great.
Yeah.
Success.
Over here?
Okay. Thank you very much. As a clinical dietitian and one who has worked with enteral feedings for a very long time, very interesting. I want to encourage you as you do go forward with publishing. Of course, Dr. Stallings' excellent suggestions, but additionally, if you can include information, if you have it, regarding how much of the child's total nutrition was the enteral nutrition providing. And I think that that's an important concept because, as we all know with CF, it's not one or the other.
Right.
It's always both. The second point is for these prospective studies that are so desperately needed, to consider collaborative because no one center has enough to get those numbers where we need it. And any information on enteral feeding for children with CF is desperately needed. Thank you for your work. That was excellent. I really appreciated it.
Absolutely. Thank you so much.
I echo the sentiments. Excellent, excellent project, excellent presentation. I had a quick question. From a person or a physician who sees a lot of steatosis, have you noticed that maybe we're overshooting? I recognize that your slide where you had that 50th percentile where the aim is, it didn't seem like the FEV1 or anything really improved after 50th percentile. And I wonder if we should maybe create another line at the 85th percentile and say maybe we should stay under this and not just push for the 50th and continue to go above and above and above, because after a while we're going to have to start, peeling back a lot of the side effects of having extra fat inside of the liver and figuring out, is this HBI? Is this mast cell? And so food for thought.
No, I 100% agree. I actually attended a talk earlier that actually discussed that same point about whether we should be peeling back that goal, especially in the setting of modulators and seeing how prevalent now obesity and more weight concerns are becoming.
Great talk. My first project, as I shared, was about G-tubes in CF. My question for you is, how many of your patients needed either endoscopic or surgical closure of the fistula? Do you know the answer to that?
Not off the top of my head. There are at least 2 to 4 that I can think of right off the top of my head. This was especially common in our older patients, as you all are familiar with, that had those long-standing G-tubes. We also had other patients with comorbidities such as eosinophilic esophagitis that needed scope, so we would try and coordinate removal, closure of the stoma, as well as the scope.
I think that just might be great information to include in a publication for anybody reading it so that they could counsel their patients. Thank you.
Congratulations. I just wondered, are gastroenterologists a regular part of your cystic fibrosis follow-up team?
Yes, every single visit.
Go ahead.
Great presentation. One more question. So you talked about the patients who you were able to remove the G-tube. Did you do any looking at what factors kept patients from still needing the G-tube? What comorbidities, or if they had worsening lung function to begin with, or otherwise didn't respond as well to ETI?
Yeah, absolutely. That's not something that we formally evaluated, but just upon review of the data, some of the other comorbidities included genetic conditions that could have compromised nutritional status. Other patients, like Dr. Lazar mentioned, especially with long-standing G-tubes, the G-tube was a sort of source of comfort and sort of this backup safety plan. So some patients I know, when they get sick, they like to have that and run tube feeds through there. So those are some of the factors that pop into my head right away.
Thank you.
So we have an online question. It says, has any patient regretted the decision or had any weight loss as a result?
We have had a couple of patients that have had weight loss at the follow-up appointment. And like I had mentioned in my presentation, our patients are very closely monitored. And so a lot of the conversations at those follow-up appointments revolve around ways to optimize our oral intake now that we don't have that G-tube backup in place, and making sure that we are following these patients a bit more closely to ensure that there is no further decline.
And one other question that I have, do you think in writing up this, there's a question about selection bias, since you have 13 out of the 35? Just for reviewers, would they think that there's some selection bias in picking out the 13 because you had some patient that had leakage and things like that? Do you think that's an issue that you should make sure that you address when you're writing up this?
Yeah, I certainly think that that is something to take into consideration. Absolutely.
Yeah.
Moving on to our next excellent speaker. All right. We have Dr. Christiana AKZ, Dr. AKZ. She's a third-year pediatric gastroenterology fellow who also is one of our Cystic Fibrosis Foundation first and second year training grant funded fellows. So she has a big interest in cystic fibrosis care and research long-term. She is at the Medical College of Wisconsin in Milwaukee. She's originally from southeastern Nigeria and has also a strong history in working with resource-limited hospitals there in Nigeria, including an HIV clinic in a rural community, and she's that's close to her heart. So just like to welcome her to talk about her project using FIS data.
Good morning, and thank you all for having me here. Thank you for this opportunity to present my project today. And today we're looking at the trends in pediatric ED visits and hospitalizations for intestinal complications in pediatric patients with cystic fibrosis. And we did a pre and post-modulator therapy analysis, and we did a multi-center retrospective cohort analysis. Okay. No disclaimers. So, like she said, this project was funded by the Cystic Fibrosis Foundation first and second year clinical award. So a bit of background for our project. We all know that gastrointestinal complications are common in people with cystic fibrosis. And just looking at the image by the side, we can see that some of the ones that are very specific to the gastrointestinal tract, we have gastroesophageal reflux disease or hyperacidity, gastroparesis, dysmotility, meconium ileus, distal intestinal obstruction syndrome, constipation, rectal prolapse, dysbiosis, inflammation. These are very common to the tract itself. But we decided to just specifically look at ileus and constipation because these are the common manifestations that will make patients come to the ED or make them hospitalized. So we felt like we could find something with these two things. So we know that we've been talking about this all week, that with the introduction of highly effective modulator therapy, that there's been an improvement in some of the outcomes for pulmonary outcomes. And looking at the first figure, we see that there's been an improvement in median survival rate. Just looking at the trend from 34 to 38, and then the big jump from 2019 to 2024, we could see that significant improvement from 46 years to 65 years. The same with figure 2, where there's decreased rates of pulmonary exacerbations. So we see that for adults, it was significant, but specifically for our population, children, we see that the exacerbations went from 21% in 2019 to 9% in 2024. So we see that there's a significant improvement, but there's really limited data on what's happening with the effect of HEMT on GI manifestations. So that was what informed this project. Now, the PROMISE GI study is one that has been quoted a lot throughout this conference, and it's one of the projects that looked at gastrointestinal symptoms. And what they did was they explored GI symptoms at baseline, and then at 1 month, 3 months, and 6 months post-HEMT initiation. And they used questionnaires to ask the participants about their symptoms. And the two that actually resonate with us was the rectal and the stool symptoms. And they reported that there was mild improvement, but it was also more noticeable in patients that had severe symptoms at baseline that appeared to have more improvement with initiation of HEMT. But they had a small sample size, so we wanted to do something bigger. So the aim of our project was to compare differences in rates of ED visits and hospitalizations for constipation and the intestinal obstruction in pediatric people with cystic fibrosis between the pre-HEMT era. And we decided to use the era, so we just divided it into 2014 to 2018 as the pre-HEMT era, since we know that the medication was introduced in 2019. And we moved the post-HEMT era as 2020 to 2024. And our hypothesis is we've seen the changes in pulmonary outcomes, so we feel like the use of HEMT would result in reduced rates of ED visits and hospital admissions for constipation and DIOS in the pediatric population. So for our methods, we did a multi-center retrospective cohort study, but we're looking at what will give us a big sample size. So we used the Pediatric Health Information System database. And this is an administrative database with about 50 standalone children's hospitals that contribute data to the database. And looking at the image above, you can see that this is, the hospitals are spread across the United States. So we feel like it's representative of all the CF patients from different parts of the United States. And the database collects encounter level data. So when the patients are admitted, they collect data using diagnosis. So the ICD 9 and 10. They look at procedures, bill transactions, and utilization. So this was a significant database to use. We included all patients with cystic fibrosis aged 2 to 18 years. And then we included all ED visits and hospitalizations with a primary or secondary diagnosis of constipation or intestinal obstruction. And again, our cohorts, like we mentioned, was a pre-HEMT 2014 to 2018 and post-HEMT 2020 to 2024. And our study outcome was the rates in ED visits and hospitalizations in the pediatric population with patients that had a primary or secondary diagnosis of constipation or intestinal obstruction in any of these two areas. So for our results, because the database is like dynamic and they keep adding hospitals, so if you look at the number, the pre-HEMT era, there were 46 hospitals that contributed data at that time. And for the post-HEMT era, there were 49 hospitals that contributed data at the time. So this table describes the demographic characteristics of the total population. And specifically looking at, I think I may have jumped, okay. Looking at the total population, we identified that they had a total of 486 ED visits. And for the 2014 to 2018 cohort, there were 295 ED visits identified, which is higher than what was identified in the 2020 to 2024 cohort, which was 191 ED visits, and this was significant. Same with the hospitalizations, there were 4,197 hospitalizations identified for the total population. And for the pre-HEMT era, there were 2,631 hospitalizations identified, which was higher than the cohorts, the post-HEMT cohort, that was 1,566, and this was also significant. So the next thing we did was just looking at the annual rates of the ED visits and the hospitalizations, and this again is for the total population of the patients that we found. And figure A is looking at the emergency department rates, and the pre-HEMT era is on this side and the post-HEMT on the side, and you can also see that it was significant because there was a drop post-HEMT when compared to pre-HEMT. Also looking at the total population for the hospitalization rates, you can also see that the post-HEMT rates were lower when compared to the pre-HEMT rates, and both of these were significant. So we did a sub-analysis trying to look at those that had constipation as their primary diagnosis at presentation and looking at the annual rates as well. So figure C, or the table, graph C also looks at the ED rates. And it's also similar to what we had for the total population with the lower rates in the post-HEMT era when compared to the pre-HEMT era. D looks at the hospitalization rates for those that had constipation as their primary diagnosis at presentation. And it's also similar. There was a downtrend, but this was sustained post-HEMT, and both of them were significant. The other sub-analysis we did was looking at patients that had intestinal obstruction as their primary diagnosis at presentation. The number of patients that presented to the ED with intestinal obstruction was minimal, so we didn't have the annual rates. But for the hospitalizations, we were able to do the graph, and we can see that there was a downtrend pre-HEMT, but this was sustained post-HEMT with just a slight uptick between 2023 and 2024, but this was still significant finding. The other thing we looked at was medications that were administered to the patients, and we found that polyethylene glycol, which is the commonest osmotic laxative we use in the hospital, was administered more pre-HEMT when compared to post-HEMT. But lactulose, senna, and gastrografin, the other medications we use in our patients, were administered less, so patients got it more in the post-HEMT era when compared to pre-HEMT. Then imaging studies, we looked at how many patients got imaging studies done, and less imaging, that's abdominal X-ray and abdominal CT, less imaging was done pre-HEMT compared to post-HEMT, so we're doing more imaging post-HEMT when compared to the pre-HEMT era. So some of the limitations of our study, we're unable to directly measure HEMT usage in the FEAST database. When patients come in for constipation clean-outs, most times they don't have all their home medications started inpatient. and the database only collects data for what is administered when the patient is on admission. So we were not able to correlate for all the patients that were actually on HEMT, but we just did the error because we assumed that most of these patients at this point were on HEMT. There's also the difficulty differentiating between acute and chronic constipation during hospitalizations. Most patients with CF have a history of constipation and already have a home bowel regimen. So when they come in, this is started, and sometimes someone takes that they have constipation, so you can't really differentiate if it's acute or chronic. And we also know that some patients have initiation of therapy from outside hospitals prior to their presentation or transfer to a FEES hospital. So some of that data is lost by the time they get to the FEES hospital. So our conclusions, looking at what we found, we feel like HEMT, we've shown that HEMT is associated with a significant reduction in ED visits and hospitalizations for constipation and intestinal obstruction among people with cystic fibrosis. But this finding suggests a broader impact of HEMT on the gastrointestinal outcomes. But we also think that there might be changes in inpatient management trends over time, which is something that we think might be a good way to look at for our next steps, whether there's been changes in the way constipation and intestinal obstruction is managed that may have contributed to some of the findings that we had. So these were our references, and I want to specifically acknowledge Dr. Mack, who is my mentor, has been really supportive and meeting with me every week for this project, and Dr. Antos, who is our CF director at Children's Wisconsin, and Dr. Kalaf, that has been mentoring me from all the way from Florida, and Dr. Morrison, who is the FEES person that was part of this, and then we have Key and Leon, who are the statisticians. And a big shout out to our CF team. Some of them stayed back to be part of this presentation. I just want to acknowledge every one of you. Thank you.
Very nice study. It's always tricky working with these large databases. It's very nice that there's many individuals to pull from, but as you rightly pointed out, there's a lot of other considerations, we have to take into account when we look at the data. Question for you is, did you consider another cohort in your analysis of looking at the later time period of 20 to 2024, those not on HEMT but have CF, as to sort of validate a little bit your other cohort in which you were comparing to your earlier cohort? I recognize that they may be genotypically a little bit different. There may be various reasons they're not on HEMT. But I also think about during that time span, there may be a number of different factors that may contribute to the management of, people's GI symptoms. One thing that just came to mind is over that time period, there have been more and more gastroenterologists engaged in more routine CF care. And I reached over to Drucy and said, when did Digest start? And she told me 2014. So I think, and that's probably not the only thing. There's probably many other things, but just something to consider if you haven't, at least as a little bit of a validation.
Yeah, that's a great contribution, and it's something we didn't consider, but it's something we can actually add to and see if there's a difference in the patients that are not on HEMT, and if that makes a difference. But again, it's difficult to actually determine those that are not on HEMT because the database only collects data on what's administered when they are inpatient. So that's why we couldn't actually do the linear trying to figure out if these patients were actually on this and the difference in need.
Fair point. Yeah, thank you.
Hi there, Frank Davis, Groningen, Netherlands. Thank you very much for a nice presentation. Following up on what Zach asked, did you take into account, in particular with the emergency department visits, that it is also the same period that it was COVID? And did you correct for that?
We did take into account, we actually thought of that, that 2020 may have contributed to that downtrend, But then we saw that there was a continuation of the downtrend even post-COVID, because when we extended it to 2024, when most of the hospitals were open, you can see that the trend still remained the same, and none of them got up to the pre-HEMT era level.
Was there some kind of control group that you could see that other patients with other disease, that they also had a decrease and an increase in visits?
No, we didn't use the control group, but we did try to match hospitals just to see if there was like a difference, and the match study is actually more significant when we look at it when they match based on the hospitals that were part of the study or part of the FEES database, that it's still the same findings that we have.
Thank you very much.
Great talk. Just to sort of follow up on Frank's question, I would also be very interested in the admission rates of patients without CF who were either admitted to the hospital or admitted to the ED for constipation. And I'm just wondering, because you are looking at era-specific, as opposed to, hey, these patients were actually on HEMT, almost like a control group. I wonder if you might be able to compare to see if that association with highly effective modulator era is actually due to that or not.
Great presentation. Kind of touching upon what other people have said, have you looked into clinic visits for the same indications, during that same era? If there's COVID going on and we have patients coming in with constipation, we might have been trying to do more outpatient management or directly admitting from the clinics rather than having them go to the ER to help prevent potential complications. So that might be something else to look into.
Yes. Unfortunately, this database only looks at inpatient and ambulatory procedures. So it doesn't look at clinic visits. So we couldn't use that for clinic visits.
Yeah. Just one question, maybe it's been asked already. Did you see any regional differences in any of your outcomes? Like, since you have 46 hospital, were there any differences in maybe outcomes?
We didn't analyze based on regions. We just did the total population, the hospitals, both pre and post.
Okay.
Yes.
Great. No questions online. Any other questions from here? No? Okay, great.
Thank you.
All right, we've all made it. So we are going to introduce our last person, Dr. Wood. So Dr. Wood comes to us from Dallas, Texas, UT Southwestern and Children's Medical Center, and he is a first-year pediatric gastroenterology fellow, where he is also a Cystic Fibrosis Foundation-funded fellow as well, and he is going to talk to us about quantitative MRI. Come on up, Dr. Wood.
Good afternoon, y'all. Start. You're okay. Okay, so my name's William Wood. As I introduced, I'm one of the first-year fellows down in Dallas in gastroenterology. So the study that I'm presenting today is looking at the utility of quantitative MRI imaging to assess hepatobiliary manifestations in persons with cystic fibrosis. For my first disclosure slide, I am funded through the CFF Foundation on the first and second year grant. And then maybe you all saw Dr. Freeman's presentation yesterday. I think it's important that I disclose I am not a radiologist, and please always remember to clinically correlate. So as an introduction, liver disease and cystic fibrosis is an important cause of morbidity and mortality. The diagnosis is quite challenging. There's variability in clinical presentation, patchy hepatic involvement, and there's an indolent nature to this disease. As many have touched on, the PUSH study illuminated the importance of imaging with ultrasound. Unfortunately, ultrasound is user-dependent, and there's been concern for reliability in between patients. Additionally, there are limitations to POCTE, also known as FibroScan, as it's user-dependent and can miss patchy fibrosis. As touched on in previous presentations, new definitions for liver disease in persons with cystic fibrosis came out in 2023. CFHBI is the more mild form of the disease, while ACFLD is more advanced. Guidelines define the disease state through a variety of parameters. On this slide, I'm listing the imaging parameters for POCTE, as well as ultrasound elastography. So thought process and considerations for our study. MRI is not routinely used for screening and monitoring in liver disease in persons with cystic fibrosis, but it may offer some notable advantages. That being that we'd be able to provide discrete values to follow over time, much like biomarkers. And it also allows for more complete assessment of the liver parenchyma as compared to POCTE. Within MRI, there are multiple ways to evaluate the liver, and I'll go through these in a little more detail. So in this slide, I have a nice table kind of showing you what all MRI can do for us. We have lesion-specific contrast that allows us to visualize the different lesions, specifically tumors. Elastography has been touched on quite a bit, measuring stiffness and evaluation for fibrosis. What multiparametric MRI can help us with is iron-corrected T1 mapping. This allows us to evaluate for fibrosis and inflammation. Of note, the liver is quite iron-rich, and so iron levels have to be corrected for, and that's where this naming comes from. Next is proton density fat fraction, which allows us to evaluate fat content in both the liver, the spleen, and the pancreas. And then we also have quantitative MRCP, which allows us to better measure the biliary tree and looking for anatomical changes like strictures and anomalies. And so I know this slide has quite a bit going on, but these are kind of the imaging results that you'll see in multi-organ assessment. These include a multitude of images, and I'll go into further detail on each of these. So looking at our multiparametric MRI with specifically the liver, this is a non-contrast MRI scan. It allows us to follow 3 markers of the disease, as I mentioned. So our CT1, looking at inflammation and fibrosis, liver fat, with our PDFF and iron content. And of note, this scan is standardized across multiple machines, so it can be used in a variety of places. Next is quantitative MRCP. Quantitative MRCP uses conventional MRCP and applies an AI-driven tubular enhancement, which suppresses gastrointestinal contamination and noise to produce a 3D quantitative model of mapping the biliary tree. The report contains measures of the biliary tree volume, gallbladder volume, as well as measures of all major ducts, in addition to assessment of ductal dimensions and number of ducts with pathologies like strictures or dilations. In this lower portion, next to 3, we can see that warmer colors indicate strictures, while cooler colors indicate dilations. Next is pancreatic fat. So elevated pancreatic fat is characteristic of CFLD. Within these multiparametric MRIs, we can look at local assessment as well as segmental assessment. And we can also look at the spleen. T1 values have also been used as biomarkers for good outcomes in patients with changes in their spleen. We can also look at spleen volume, as this is also associated with cirrhosis and advanced liver disease. So going back to our study, our aims were to look at quantitative evaluation of our GI system using multiparametric MRI, looking at CF patients with no liver disease versus those with CF-HBI versus those with ACFLD. With a secondary aim being to explore quantitative MRCP and seeing what utility that has as well. So methods, with our enrollment, this study started several years ago. We were looking at POCTE for FibroScan stiffness measures, and using those to help categorize patients into groups that were showing disease versus those who were not. These were collected 3 to 6 months before our MRI. With age, we were looking at patients over the age of 3 who do not need to be sedated. And these patients also need to have a documented genetic or sweat chloride testing to confirm the CF diagnosis. After this, multi-parametric MRI and repeat lab work was done within 6 months of evaluation. So looking at demographics and categorizations, this study was done in Dallas, Texas at a tertiary care children's hospital. Within our system, we have 285 patients or persons with cystic fibrosis. We were able to collect 13 patients or enroll 13 patients who were interested in doing the study. Within this cohort, our population is predominantly white, predominantly male, and predominantly 508 homozygous. Looking at statistics, we use t-testing and ANOVA to evaluate 2 different groups. So within our first group, we are looking at patients who do not have any signs of liver disease, and then we are grouping together CFHBI as well as ACFLD. And then in our second set of testing, we are looking at each of these 3 individually. So looking at this first group, our 2-group analysis, we found that our baseline lab work was pretty consistent with known values that we believe will help us evaluate the disease state. Within our data, we found that we found significant differences as expected, and we did not see significant differences as expected that we would see in POCTE. Going on to the next slide. Looking at further analysis here within our MRI data, when we go further, we see that although not significant and likely due to sample sizing, there is some notable trends. So the first one being our liver CT1. We see that we have a notably higher trend as we go from those without disease when compared to those without, or with disease, excuse me. We also see with liver PDFF that this was higher in our CFHBI and ACFLD group compared to those with no liver disease. And then within the pancreas, we see the PDFF was also over 2.5 times the higher limit in the ACFLD and CFHBI group as compared to those with no liver disease. Looking at our MRCP data, we're seeing that patients with CFHBI and ACFLD showed more ducts with strictures and dilations compared to those without liver disease. And then going to our 3-group analysis, we were also able to see some of the same patterns that we'd seen in previous studies, where our lab work, our baseline lab work, and our baseline POCTE is showing more disease state in those with disease than those without, and it's progressively worsening. Similar to the results observed in our 2-group analysis, liver CT1, liver PDFF, and pancreas PDFF were all higher in CFHBI and ACFLD groups compared to those with no CFLD. Taking a closer look at the quantitative MRCP findings, we see that those with ACFLD had a higher number of ducts with pathology compared to those with CFHBI. From a disease severity perspective, this is expected because advanced CFLD reflects progressive biliary damage, where chronic inflammation and fibrosis lead to more extensive strictures, ductal dilations, and architectural distortion. So discussing these results. In this study, we found kind of some expected changes in our POCTE and our lab work biochemical markers. With our multi-parametric MRI, we also found differences in CT1, liver PDFF, and pancreatic PDFF. We also saw some expected changes in our MRCP. And although not significantly statistically different, patterns of increasing CT1 and PDFF in more advanced disease may reflect worsening steatosis, fibrosis, and inflammation. Obviously, we had some limitations. Our sample size is restrictive in our analysis. We had lack of demographic variability. And then we had lack of normative values to compare to. And there's also an issue with cost and availability with getting multiple MRIs done. So conclusions. The differentiation between ACFLD, CFHBI, and those without liver disease is complex. In the study, differences between the three groups were found in some POCTE and biochemical markers. Clinically helpful patterns were identified with hepatic MRI evaluation of fibrosis, inflammation, and steatosis. And there's a need to explore the role of quantitative MRI in healthy CF patients, as well as those with disease, in larger cohorts to better understand the potential utility of MRI in the future. So some key points and takeaways. So the basics for this study. Our question was asking whether or not MRI is a viable tool for evaluating liver disease in persons with CF. What we found in this pilot study was that there are some statistically, there's some lack of statistical significance due to our sample size, we believe, but we think that there are some important trends that should be followed in larger studies. And the ultimate significance of this is that in the modulator era, persons with cystic fibrosis continue to live longer and healthier lives. The impact of CF on the liver now requires closer examination for long-term care of children into adulthood, and MRI may play an important role in this evaluation. My citations, and thank you all for listening.
All right, we'll take some questions. Dr. Narkowitz.
I know you expected me to get up on this one. So it's a really nice study. I think the addition of the quantitative is important. You cited our study with 100 that is identical. I'm going to disagree with your last conclusion. I don't think we need to study this in normal individuals with CF. The utility of this, you showed actually nicely that our biomarkers can actually pretty accurately identify advanced liver disease on the ones that we have. So personally, and from a hospital finance person, I don't see any utility of doing this for liver in normal. I am struck by the quantitative bile duct data, which I think is really interesting and may tell us something about the pathogenesis. So I would just advocate, if we're going to do this, we ought to focus on trying to understand mechanism and use your quantitative to show biliary injury in that space. That would be, personally, I think the broader one, it's going to be a non-starter in grants, I can tell you that with it. So I'm going to come back to it. How do we differentiate true structural biliary injury in a disorder that has significant biliary fibrosis and inflammation? And is it a bile duct structure, or is it an impingement issue, which is always sort of and maybe it doesn't make any difference. So it'd be nice to try and correlate those with outcome.
Yeah, absolutely. I think that's going to be the challenge moving forward, is trying to establish those normative values and figuring out what our real cutoffs are using this more discrete value.
Yeah. You might not have to describe normative values. You might have to say, as you follow your advanced patients longer and they have adverse outcomes, looking back to see if they were predictors. Fair. That's how I see value in this type of work in the way I think about it. You're going to get a different opinion.
I think that's a very good point, though, because this was brought to us as something very exciting to monitor that CT1 value. This technology has been used actually quite a bit, I guess, in hepatic steatosis, MASLD, and MASH, and following that CT1 over time after you do interventions for your MASH patients. And so the overlap in application with hepatic steatosis as a manifestation in CF. But then we got a lot more excited about these volume ideas, whether it was the spleen, the biliary tree, et cetera, in terms of monitoring those more severe patients. So I think that's a really, really good point. Go ahead.
Thank you very much. Impressive presentation. I was wondering, could you speculate? I know your numbers are small, but we know that advanced liver disease is divided in cirrhotic and non-cirrhotic disease. You speculate if the quantitative MRI can shed any light on the differentiation between these two phenomena? You might also see like vascular abnormalities or things like that.
Yeah, I think that's definitely a goal, is being able to differentiate and give better guidelines of our three categories. At this point in time, I don't think I could make that call as to exactly where those cutoffs would be.
We don't know from other diseases, other forms of non-cirrhotic portal hypertension, if there's any specific findings on this quantitative MRI?
So that CT1 value is also used to evaluate MASLD. And so that's where it kind of draws from, is looking at disease progression. We're hoping that would also help us kind of lay that groundwork. Yeah.
Great talk. Another CF Foundation funded fellow, so way to go, Foundation. I couldn't help but notice that as you compared those without CF hepatobiliary involvement, those with CF hepatobiliary involvement, and then those with advanced CFLD, there was a significant drop-off in platelet count, especially in those with advanced CFLD. And since you did the MRI anyways and placed the paddle over the liver to measure liver stiffness, did you happen to measure spleen stiffness? You know, there's a lot of concern about patchiness and heterogeneity of the CF liver, but we know that portal hypertension, whether it's cirrhotic or non-cirrhotic, is sort of the end result of advanced CF liver disease. And spleen stiffness might actually be very, very informative.
Yeah, I'd have to go back through our data and check. I'm not sure off the top of my head if we just have spleen stiffness or if we just have spleen volume. I think we're using volume primarily.
Just to piggyback on that, that was what I was asking Lauren about that were there abnormal findings or unusual findings in the spleen and the pancreas in what, when you were doing your studies that you can share with us? Just unusual findings in both the spleen or the pancreas that you can share with, because we're focusing on the liver, were there other things that you found that you can share with us in both the spleen and the pancreas? Just piggybacking on that.
Yeah, you know, I targeted the most pertinent information in this.
Okay.
I don't have much more to give you. I'm sorry.
Oh, okay. Thank you. Just wanted to know. It's something that you can also look at if there was anything that would be very informative. Yeah.
Yeah, I'm just pulling some stuff up, cheating a bit, I guess. But yeah, I don't think we did look at spleen stiffness, but we've talked about this a lot, spleen stiffness. And so we can certainly go back to them and see if that's data that they can pull. But we did look at spleen volume, and then there was information pulled on the pancreas fat fraction. But I think really looking at that, and I think that tends to be elevated anyway in this population. But yeah, let me see. I think it was a little elevated, but not necessarily statistically significant. So again, very small group of people, but.
Yeah, these reports are pages and pages and pages of like random values in some people's minds. And so teasing out exactly what's important and how to put it all together is something we're working with our radiology team on.
Thank you.
If there are no other questions or comments, this has been an exciting moment. I hope you all gained something from this session, and thank you so much for joining us.